I'm Dawn Marie Solis with NS 2022 Neurodiversity Conference, and I am here with Dr. Linda Bluestein, and she is a medical doctor. Her original path was, oh, my words just ran away from me. You do the gas mask, the thing. What do you do?
Anesthesiologist.
Anesthesiology. Thank you.
Well, you know what? Actually, it's really good that you said that because some people might go anesthesiologist. I don't know what that is. So you gave them like an additional clue. So that's good.
Yeah, there's the gas and the drugs and all the things. You help
all
us
the things
become comfortable and calm and wonderful when we have to have invasive things done. So thank you. But you have also found this new world, this specialty of hypermobility, which is super important for the neurodivergent community, but really misunderstood, not known, all kinds of knots, right, out there in the medical world. You are part of this little wonderful package within INIS that is hypermobility. I'm talking to a few other people, and from my own selfish perspective, thank you, because it's part of my world, and so this is a lot of fun. But I'm almost desperate. Probably not almost. I am desperate. The world needs to know this stuff. There's too much. I was just talking to Dr. Eccles about the body-brain interconnection and hypermobility and the full system impact and all of that stuff. So it's too important. If we don't know about it, we cannot provide the proper care. Not even allopathically, but emotional therapeutics. She was just telling me about connections with depression in teens, and like, it's just blowing my mind. I will eventually let you talk. My autism is showing. I'm just so excited about this topic, and that I'm finding brilliant, beautiful people to talk to me about it. So Dr. Bluestein, thank you so much for being willing to take your time and add your sense of all of this stuff to the package.
You're most welcome.
How did you, I mean, if you started in anesthesiology, how did you land in this world?
So I was working as an anesthesiologist, and I had had quite a few medical problems throughout my life. I mean, including like in infancy and things like that. And I started getting more and more complex problems, injuries, all kinds of different things. And I kept asking my doctors, what's wrong with me? I think there's something that we're missing. And of course, they kept saying, you're fine, you're fine, you're fine in in my 5-minute visits, right? Periodically. And even when I was seeing orthopedic surgeons for injuries that should not have happened with the type of trauma that took place, still, and then, this is at the Mayo Clinic where I trained, and I had a great orthopedic surgeon for my elbow who's measuring my range of motion. And all he said is that like 20-degree plus of hyperextension that you have will go away after the surgery. That's all he said. Nothing about what the hyperextension might mean. And, granted that this is maybe I think around 2005. And of course we didn't know anywhere near as much then as we do now. So like you said, now is our time. And now for Bendy Bodies, now is the time. Now is our time. For sure. So I ended up having I fell this morning, so I had to put this back on just for a little protection. I had a bone grafting surgery on my wrist. I developed a huge cyst inside one of the bones in my wrist, and I had bone grafting surgery, and I had a complication after that. And I'd already had major elbow surgery. I had an unstable shoulder, and now adding on top of that, I had these wrist problems, and I could no longer manage an airway. And that is an absolutely crucial thing as an anesthesiologist that you must be able to do. So that was when I was unable to work in the operating room anymore. And that was psychologically devastating. I already had, a career pivot once because I wanted to be a professional ballet dancer, and that didn't work out. So I had to come up with plan B, which was medicine, and trained, it's 12 years normally to become an anesthesiologist after high school. Did that for over 20 years, but then developed these problems, and I was diagnosed in 2012 with hypermobile EDS. My notes actually say suspected classical, but I'm quite confident that it was hypermobile. So anyway, I was diagnosed in 2012, but I was told, like so many people can relate to, this is what you have, but there's nothing you can do about it. And so I literally have spent the past decade proving him wrong every single day, every moment, every waking moment. I am working to prove him wrong. So I mean, he's a lovely man, and I don't mean criticism of him, but we need more tools, and there are things that we can do. I mean, you were just sharing with me a brilliant tool that people can use, and the whole thing is to let people know that hypermobility is not hopeless. There are so many different things that we can do to improve our quality of life.
Thank you. First, thank you. Like, for taking what you knew within your being, that no, that cannot be true. This idea that we just have to accept it and live with it. You didn't accept it, and you've been working so hard and diligently. Thank you. I think about, I've been excused about making everything the Dawn Marie show. And I now understand it as part of my autism because I'm so devoted to honesty. I don't feel comfortable talking about other people's lives, right? So constantly use my experience as the example point, just because I can speak about it in a valid and honest way. So here we go. When Dawn Marie was a child, I did gymnastics, I did ballet, and I remember trying to tell people the things that were happening while I did those arts and sports, but also the pains that I would have growing up, and the fact that my right hip would not stay in place. And I didn't really have to do anything to have it pop out. I could just be sitting on the couch watching TV with the fam, and all of a sudden my right hip is like, and I have to push it back in. And trying to convince anybody who would ask me to run, right? So if it was for sports, if it was for school, anybody who would ask me to run, that makes every single thing hurt. Like spectacularly. My bowels hurt, my ankles hurt, my knees hurt, my chest hurts, and they would just tell me I was being dramatic and trying to get out of a thing. And this was just one more way where who I was being invalidated. I now understand my identity as a neurodivergent person, and that unfortunately we experience that invalidation of our self-knowledge of our being constantly.
Yes.
But when we walk into a medical office, that is the last place that invalidation should happen. And I think when you're hypermobile and people don't understand what that is, and whether you understand that it's going on or you've done your research and you show up, right?
Right. Yep.
It's like, you want people to take you seriously.
Right.
And this is just one of those spaces where I feel like a lot of us are meeting with the blank stare. That's almost the best reaction, the blank stare, or okay, fine, we'll run all the tests, and then they look at you and they don't see anything wrong. Right. They'll do the gastronomy and they're like, no, you're fine. No, but I'm having all the intestinal problems, right? They'll do the CTs, and CTs don't pick up the connective tissue, right? They'll do these tests and keep telling us you're fine, you're fine, you're fine.
Right.
Ugh.
Yeah. Somewhere along the way, I'm not exactly sure when this happened. It's not like physicians woke up one morning and said, intentionally, we're going to change from believing the patient to believing the studies. We are no longer going to take their word for it. We will only take their word for it when we get positive findings on the laboratory tests and or on the imaging. It's not like people woke up one morning and said, you know what, this is going to be a better way. But excuse me, unfortunately, healthcare is so dysfunctional. Physicians are up against so many hurdles, and it is so challenging to practice medicine nowadays. When I see statistics about burnout and they say, 60%, 70%, whatever it might be, I think, no, it's 100%. I mean, most everybody is suffering from this. So the current healthcare system is horrible for hypermobile people, absolutely horrible. We need, like you're saying, we need time to explain what's going on in our bodies. We need time to forge that relationship with the physician, the nurse practitioner, whoever it is that we're seeing, and to make that connection. And a lot of us are neurodivergent, so we need even more time than other people might need. And then on top of that, these are not acute, discrete problems. We have multi-systemic problems. So we need somebody who's going to look at things from a big picture standpoint. But now care is so fractionated. We are working in these silos. We also have so many constraints. We have regulatory constraints, insurance, our practices are telling us, not me, because I work for myself, but for most people in a standard medical practice, they're told, well, now you have to see 40 patients in a day. Can you imagine seeing 40 people with hypermobility in a day? I mean, I don't even see 10 in a day. I see a very small number of patients on purpose, but nobody could sustain from a financial standpoint. Like, they couldn't sustain that in the insurance model. So our current healthcare system, it's like trying to fit not just a square peg into a round hole, but it's like trying to fit this massive, this massive bolt into this tiny little opening that it just doesn't, it's just a terrible fit right now.
Yeah. And I think for neurodivergent people, like you said, sometimes we need a little bit more time and stuff like that. I mean, just entering this conversation with you, I refer to my ADHD as either cats or monkeys. So my monkeys are really happy right now, right? They're engaged and they're like bouncing at their branches and they're swinging around and they're mischievous and they swipe my words and they run away. And I don't know when they're going to come back. They usually do. Sometimes they don't, right? So if I'm under stress, if I'm whatever, right, and my cats take over, then I have almost no words left because
Right.
my brain cats are like licking themselves in the corner saying, I'm not talking to you right now, right? So
Right.
depending on how I'm processing, what I'm doing, I forget so much of what I want to say in a meeting.
Right.
If I don't have an advocate with me who's like trained to help me and right, or if I come with the written list, I find the written list is the fastest way to get care removed.
Oh, to get care removed?
Oh yeah, in my personal experience, I know
In-
other people have experienced differently, but if I bring something and I'm like, here's my list.
Mhm.
Now, I might bring really long lists.
We can talk about that, actually.
But if the way I may end up in an office, depending on the attitude of the person I'm with,
Mhm.
I may find a removal of care.
Mhm.
Somebody's frustrated with me right off the bat. They've made
Right.
decisions about me right off the bat. Um, so when you're hypermobile, you have a long list.
Right.
I did
Yeah.
that for you,
Yeah.
right?
You do.
And often I will say, I have a thing, right? It's top of my list. And I'll say, and I have a thing. And they're like, oh, no, no, no. Let's focus. And my brain melts down because no, you can't, because they're all related,
Right.
right? I mentioned, and they won't let me talk about because we're going to focus, right? So I'm sent to the spine, the upper spine dude, and I'm sent to the hip person, I'm sent to the hand person, and I'm sent to the neurologist. I've sent to all of these people, and none of them talk to each other, and I'm not getting better.
Right.
And everybody wants to prescribe a medication,
Right.
right? My neurologist is currently mad at me because I don't want to take any more pain medication. I'm like, well, the pain medications aren't working. He's like, well, I don't know what to do for you then.
Right. Right. They don't know what else to do. Yeah.
So it's part of my, yes, I have personal investment in this conversation. I will not shy away from that, right? But I'm so intensely inspired to help get this information out because I am not the only one. It is not, yes, it is about me, but it is not just about me. And it is not just about people in the United States. It is not just about a certain category of people. It's about everyone. The way we look at the human experience in medicine is, in my opinion, fundamentally flawed. And to me, hypermobility is this thing that can maybe help us change the perspective because it is proven to be fully integrated in the whole system. We have to look at the whole human in order to get hypermobility right. Diagnostically, therapeutically, medicated, right? We have to see the whole human.
Yes.
So I see this as important within the community of folks, those of us who are hypermobile, but as a pathway to fundamentally change the perspective of medicine as we have it at this moment.
Yes, absolutely.
What's happening in your world as you approach this? Are you finding that the pathway, or like that's just like, yes, I hope that happens, but I have to stay like focused and in my lane, or what's going on for you?
So I'm finding people coming to me, emailing me. I have a podcast called the Bendy Bodies with a Hypermobility MD. And I have people contacting me from all over the world. Like you said, this is not a United States problem. This is not a UK problem. This is an international problem. Symptomatic hypermobility is a huge problem, and it appears to be increasing. It's a little bit hard to know for sure because, data collection is not easy to do it really clean and really well. And that's what I love about Dr. Jessica Eccles. She is such an amazing researcher. The way she approaches things is very, very clean. She's so scientific. She's such a great researcher. I interviewed her twice for my podcast, and we have gotten such amazing feedback about those interviews. Somebody the other day actually used they used the F word because they were so blown away. They shared it to their story on Instagram, and they're like, I'm so effing, they were so blown away by that conversation, and because it was so eye-opening, because a lot of us don't realize how our brains work differently than the quote unquote like average person or the quote unquote normal brain, of which there is no thing, right? But hypermobility is so important because yes, it appears that it's highly, highly correlated with neurodivergency. It is highly correlated with chronic pain. And to me, this has reached the point of, it's a public health crisis. If we don't do something, we are going to have a workforce shortage. So this is why I am trying to reach as many young people as possible and giving them tools to help their bodies and their minds function at the very best possible for two reasons. One, so that they have better quality of life. Two, maybe more than two. Two, so that they have the ability to be physically active for as long as possible so that they can, have a rewarding career. And then the fourth thing, selfishly, I keep thinking, who's going to take care of me when I'm older, and who's going to be, we already know that the workforce, we're having issues. It could get even worse if we don't help people. And having a job, for me, when I couldn't work as an anesthesiologist anymore, and I just dove into hypermobility and learning everything that I possibly could, initially just to help myself. But then as it became, I wrote a paper, and then I opened my practice. And as it's become a bigger and bigger part of my life, it's so rewarding. And I think that we all have a purpose on this earth. And if we can identify that purpose, it gives us meaning in our life, and it can really just help improve our quality of life. I mean, from a pain standpoint, My pain is the lowest that it has been in it is the lowest that it has been since 2009. I started to say over a decade, but I can pinpoint exactly July 14th of 2009. Fell off a mountain bike and my body was never the same after that. So, it is not hopeless. There are things that you can do. The brain changes and the nervous system changes with chronic pain. We know that there are things that happen within the nervous system that pain begets pain. And it's a chemical thing. This is not, don't blame yourself if this has happened to you. It happened to me. But there are things that we can do to reverse that. But the sooner we do it, the better. The sooner that we recognize that we're hypermobile, the sooner that we recognize that we're at risk for developing certain problems, the more that we can take action and make better choices.
Yeah. Again, within my personal experience, I found out about hypermobility through a client of mine who discovered it for herself and for her kids. Gratefully, her kids are tiny. However, the battle she had
Mm,
to get anybody to listen to her, and is still in that battle.
right.
But even with people listening to her, the best they've got is diagnoses. They don't really have a plan. And then, as she was telling me about her struggles, not too long after she recognized hypermobility for herself and her kids, I got hit by technically my own car. Somebody hit my car hit me. And the path through the medical system that I've taken, I think would have been massively benefited. One, if I'd known I was hypermobile before I got hit. And two, if anybody else had decided to think about it. And so now I'm asking for care based on the idea that I'm hypermobile, but I'm not finding people in my area who really understand it. And I'm being told out of town, out of town, out of town. Like neurodivergent people, it's hard, right? It's hard enough to go see the one person,
Right.
And if they believe you, woohoo, right? Great,
Right.
awesome, thank you. And then they tell you, go away.
Right. Right.
So access to care, and I talked to a couple of folks from Autistic Doctors International. They have this amazing paper that they released a couple of months ago about access to care for neurodivergent people and all the things that are impediments. This is one of those things, right? So if we don't have good primary care or general practitioner care knowledge, we will be specialized until we can't. Please don't give me one more specialist. Please don't send me in one more direct. Can somebody please know enough?
Right.
And so when you're talking about this convergence of hypermobility in the neurodivergent community, there are all of those aspects to it. How much executive functioning, how much stimulation, what are we even asking of a neurodivergent person in the medical space to even get the help that they would need? So from my perspective, a broadcasting, an enormous net of information needs to be cast simply to help the neurodivergent community not be specialized into inability to access care. Don't ask me to make one more phone call. Don't ask me to go one more place. Please don't send me out of town, right? The number of things that we're asked to do can eventually become an impediment to us even being able to access the care, even if we can find it.
Right, right. And it's hard enough for someone who's not neurodivergent, but for someone who is neurodivergent, right, you have all those additional hurdles. And then what I think often happens, like you were saying earlier, is we get judged for, oh, well, you didn't follow through. And oftentimes, again, in a 5-minute visit, oh, you didn't do blah, blah, blah that I prescribed last time, or, it might be a referral or whatever. And then they just think you're not compliant, and therefore I'm not even going to try to work with you. Not even to ask why, the reasons why. Because you know why? Because that takes time. Asking why takes additional time. So, again, it comes back to people especially with people with neurodivergency, they need more time with their providers. And that's like the last thing that we are giving people right now is our time. I mean, I know people who see 60 patients in a day. Can you imagine seeing that many people in a day that have hypermobility, that have, even if they're like on the healthier end of hypermobility, you can't prescribe a comprehensive treatment plan. I mean, that's what I do, is I try to approach things from a very holistic view. And I'm not an expert in neurology. I'm not a neurologist. But if I need to, I can refer somebody to a neurologist. But a lot of my patients and clients have referred to me as their quarterback, because I try to take the big picture view that really no one else is taking. And I try to say, well, let's try these different treatment approaches, and then let's come back and let's see what is and isn't working. And then we tweak things from there. To me, it's like a software update on your phone. Nobody thinks twice of doing, the software updates on their phone. And oftentimes it's like, man, I just updated that a few days ago and I have to update it again already. That's how medical care should be. We should be constantly tweaking our plan and saying, okay, you tried that, it didn't work. Let's try this other thing. But again, it takes time with the provider to really have that conversation, and for them to understand, no, this person is trying, but they're working with these other challenges that they have, and we're asking them to do these difficult things. And the EDS Society has an incredible program for training healthcare practitioners called ECHO. The ECHO programs are really fantastic. They're out of the University of New Mexico. And I joined one of their ECHO programs many years ago for pain management. Before I opened my practice, I joined that program so that that was one of the great ways to learn, virtually. You didn't have to leave your house or anything. So it really, this program allows healthcare practitioners, healthcare providers to learn more about hypermobility and associated conditions. So that's one resource that I would recommend. I also, of course, would recommend that people listen to my podcast, especially the 2 interviews with Dr. Eccles, because again, she's an amazing resource, and I love to get feedback. So if people say, those episodes were helpful, but we need blah, 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 I'm always planning, okay, you got to plan ahead. What are the next interviews going to look like, or whatever. So that's a way for people to get free information, because of course, working one-on-one with somebody, when people work one-on-one with me, it is expensive. Oftentimes though, they only see me once. So it's expensive, but it's a way to get like the big picture view that, if you sit down with me for 2 hours or an hour, that's not something that, it's like, where else are you going to get that kind of thing? And not to like promote that too much, but it's just, it's another option for people. And I'm in the process of offering other things that are in between free and really expensive. Because, I think there's a lot that we can learn from like programs like what you're doing. I think this is an amazing tool, and it's an amazing way for people to learn, at this level. They could, why are we spending time in one-on-one visits with things that could be learned on a more, I hate to reuse the word generic, but for lack of it's not personalized or individualized. So all the time when I'm doing one-on-one sessions, I'll say, go listen to this interview, go listen to, I'll give them all these resources. And like you mentioned to me something before we started the official interview, I'm adding that to my list of resources. I was working with somebody this morning. I was interviewed for a podcast, and I added things from there. I am constantly updating my own software and adding things to my resources. And then as I see how my patients respond, my patients and my clients, when I see how they respond to things, then I adapt accordingly. So even if it's not official research, because that's the other thing is doctors will say, well, there's no FDA approved medication for EDS. There's no FDA approved medication for mast cell activation syndrome, et cetera. That doesn't mean there's nothing that we can do. We always have to consider the risks and the benefits. And for some of these things, the risks are next to nothing. So why are we not trying to work on these things? And the risks of validation are 0.0. So at the very least, like you said, we need to be believing the person. We need to start with that perspective of believing what they say, taking what they say at face value, and not, yes, as physicians, we need to be judging and we need to be formulating an opinion. And, that is our job, to sort through all the information, which, but we don't need to come across as judgmental or questioning the person's story or doubting. Right? We should never be doubting what the person is saying. That is their lived experience. I don't know what your lived experience is like. Only you know. We should take that and then we say, okay, this is what we can do. Here are some things. I mean, all of the PCPs in the whole world should have some tools for chronic pain. They should know, here's some things for chronic pain that people can do that are safe. And, they're not giving people any tools. They may or may not prescribe a medication, but they don't know what else to do. If they don't prescribe a medication, they don't know what to do. In their minds, because they're so overwhelmed with things, in their minds, they've got non-steroidal medications. They've got opioids, which they probably are not going to prescribe, which is probably appropriate in most instances. And maybe Tylenol or something, acetaminophen. And that's pretty much, I mean, it's not like they know the whole gamut, but at the same time, they have to know how to treat UTIs and pneumonia and, basic wound care and, injuries. And they need to know a lot of things, but they should have a subset of things about hypermobility that they know. There's a great, it's the EDS toolkit. I can share the link with you if you don't know what this is. Yeah. And I would love that paper that you mentioned. So we could exchange those resources. But there's an EDS toolkit that was designed for PCPs that is a fabulous resource, because not all PCPs are going to join the EDS Echo program. It's time consuming. Everyone has limited time, and, a lot of PCPs, they're raising a family, they're working full time, they're working very hard. They've got a lot of constraints, so they're not going to join the EDS Echo program. However, they can go online and look at this EDS toolkit. So I would recommend that patients, you were talking about like the symptom list, and it is very challenging. I was just interviewed for a podcast called I think it's called the Hardy podcast, HARDY, the Hardy Mom podcast. That's what it was. And I talked in that interview about some very specific things that you can do in your medical appointments to get better care. So I would really recommend that people listen to that, because it's a very general conversation about how to work with your doctor to get more out of your appointments. So I'd recommend that people listen to that. I recommend that healthcare professionals check out that EDS toolkit, because it's really well organized so that you can quickly look and see, okay, I've got a patient in front of me. They have joint pain. They have gastrointestinal problems. What are some pretty easy things that I can do? Just find a starting point. And that starting point, again, is validation first, but give them something that they can do, because most of the time what's happening is we're getting nothing. And even I know of some some training programs that have a specialty EDS clinic. They make the diagnosis, they'll see you back one time, and then you're done. And they don't prescribe treatment plans. And that's a huge problem. That is a huge problem. People need a comprehensive treatment plan, especially with hypermobility.
Yeah, right. And depending on what flavor of neurodivergent you are, I'm somebody who needs really, really specific instructions.
Mm-hmm.
I finally was able to get the right kind of physical therapy, because when I got hit by the car, traumatic brain injury, stuff like that, post concussion syndrome, all of that, and gratefully, he's really responsive to, please tell me exactly what you want me to do.
Right.
Don't say, come stand here. Say, come stand in this spot on the floor, facing this way, because we're going to do this thing.
Right.
And gratefully, he just picked that up like it was nothing. Right?
Mhm.
Oh, okay, that's what you mean, fine. And he does that for me now, and he remembers, and it's just beautiful. That is the first time I've ever had that experience.
Mhm.
Normally, when I tell people, please give me all the details, I get huffed at and eye rolled at, and like, like I'm being difficult, I'm being demanding, too
Right.
much, whatever. But you were talking about the sort of non-compliance thing.
Mhm.
Even with this beautiful physical therapist who knows what to tell me in the office, right? He'll say things like, go home and do this, but if it aggravates your symptoms, stop.
Mhm.
Existence aggravates my symptoms, right? I don't. So how do you get better? Because if I do the thing and I feel worse, I'm supposed to stop. But if I don't do the thing, I'm gonna always be. And so I
Right.
go home and I think about doing the things I'm supposed to do at home, and I just get overwhelmed. And then I don't do the things at home.
Right.
Right? I like, well, should I do it in the morning? Should I do it in the afternoon? What if
Right.
the symptoms get worse? And then it complicates my day. I get so many of the what ifs going,
Right.
I don't do it at home.
Mhm.
I'll do anything you tell me to do in the office.
Mhm.
You send me home, and even with the best instructions, if anything is the slightest bit nebulous, my brain will find a way to avoid the activity. And now I go, and then it's like, well, you're not doing what you're told to do, right? Not the physical therapist, other people, right? You're not doing what you're told to do.
Right. Right.
I know. I know, right?
Uh-huh.
But because people don't understand neurodivergence, they just
Right.
see somebody who's being difficult.
Right.
Well,
Right.
if you're not going to do what I tell you to do, I can't help you.
Right.
Shoot. Right? Because I really need somebody who will help me. I need to stop hearing that I'm the problem. I mean, I get it. Like, yeah, I kind of am. But please, like, help me.
Right.
Help me. Right? It's like the Jerry Maguire, help me, help you. Right? Like, yes, please. And I think when it comes to hypermobility, or Ehlers-Danlos, and maybe you can take a second and explain to folks who might not be so familiar with this that you can be hypermobile but not have Ehlers-Danlos.
Right. Right.
Ehlers-Danlos is genetic, all that kind of stuff. And maybe we should take a second and do a little bit more. We're just expecting everybody to know what we're talking about.
Right.
We should take half a second and explain a little bit more of what these things actually mean, so that somebody can, if they don't know,
Sure.
right? But so let's do that. Let's do that first, but then maybe scoop up, how can caregivers be more aware of, you're not seeing what you think you see.
Mhm.
You're not seeing a non-compliant person. You're
Mhm.
seeing an overwhelmed, overly compliant person,
Mhm.
right?
Mhm.
I want to do exactly what you've told me to do.
Mhm.
I am compliant to my own detriment. There is nothing non-compliant about me. I just got stuck. I went home and
Right.
my brain started thinking of all the things I don't understand, and then it broke.
Mhm.
And now I can't do the thing you told me to do at home. Right? Like, we'll try again on my next visit, right? So I guess let's take a second and better define hypermobility, define Ehlers-Danlos, because I think we just sort of flew by that as an acronym.
Yes, we did.
Earlier on, right? It just, whoosh,
Right.
we drove right by that.
We did.
And if there's any other label into like any other term maybe we should know, let's take a second and do that.
Sure, sure. So hypermobility simply means greater than average range of motion of a joint or a group of joints. So a really good example, I think, is knee hyperextension. We all probably, even though we maybe didn't put a label on it, we've maybe seen somebody wearing shorts and we're like, wow, it looks like their knee is bending backwards. That is knee hyperextension. That is increased range of motion of the knee. Now, technically speaking, and I apologize that I don't have a goniometer. I'm like, I had one sitting here. I have about 12 of them in my office. I just don't have one readily available. But if you've been to a physical therapist, they've probably used a goniometer to measure your range of motion of some joint. So it's a tool, it's a plastic tool that just has like the angles on it. And for a joint to have greater than average range of motion, like for a hinge joint, for example, the knee or the elbow, it has to be greater than 10 degrees. So a little bit of hyperextension is okay. It's when it's greater than 10 degrees that it's technically considered hypermobile. So and by the way, hypermobility can occur in any joint in the body. Unfortunately, we tend to get very heavily focused on a single scoring system that was developed called the Beighton score. And the Beighton score is a great tool, especially for research, but it looks at only a small sample of joints. So it's one of these things where it's gotten used in clinical practice and in all kinds of places that it wasn't necessarily designed to be used. So we often will miss cases of hypermobility because we're using this tool that only looks at a relatively small sample of joints. It looks more at the upper extremities, et cetera. So hypermobility, increased range of motion of the joints. Okay. There are certain symptoms, which are things that we feel, or signs, which are things that other people can observe. So signs are objective, symptoms are subjective. Okay. So there's certain signs and symptoms that can occur with hypermobility that are likely attributable to hypermobility. And the biggest umbrella that I like to think of is symptomatic hypermobility. Sometimes we'll say hypermobility disorders or hypermobility syndromes, but basically what we're talking about is people who have symptomatic hypermobility. Underneath that umbrella are a lot of different conditions, many, many conditions, some hereditary, some not hereditary. So some of the hereditary things include Marfan syndrome, Lewy Dietz. People who have Down syndrome are hypermobile. We know that the Ehlers-Danlos syndromes, and that's abbreviated as EDS, the Ehlers-Danlos syndromes are a group of 14 different conditions that are genetic. Now, that doesn't mean that you necessarily got it from your mom or dad, because it could be what we call a de novo mutation. So you probably have a parent that had the condition that you have, but you might not. Some are inherited dominant and some are recessive. So anyway, the Ehlers-Danlos syndromes are the most common type of hereditary disorders of connective tissue. That's a specific thing that happens that you can get underneath the symptomatic hypermobility category. And by the way, I should say, it is also possible, though, to have, like, for example, Marfan syndrome and not have symptoms. So I'm saying symptomatic hypermobility, but technically you really could have one of these conditions and be pre-symptomatic, right? Maybe you just don't have symptoms yet, or you're just not symptomatic. So anyway, so these hereditary disorders of connective tissue, Ehlers-Danlos syndromes are the most common type. And of the Ehlers-Danlos syndromes, the hypermobile type is the most common type. Unfortunately, we do not yet know the gene or genes, probably genes, responsible for the hypermobile type of EDS. We do know the genes for the other types, or at least we know some of the genes. We may be adding to that over time. Genetics is just exploding, of course. It's an amazing field. It's really helped us to advance our knowledge of these conditions in recent years, which is amazing and super important. But in 2017, the International Consortium came up with the specific criteria for hypermobile EDS. And if you don't meet the criteria for hypermobile EDS, but you have symptomatic hypermobility, and it doesn't fall under some other explanation, what now we as healthcare professionals, like if I'm seeing somebody as a patient and they don't meet the criteria for hypermobile EDS, and I suspect they have symptomatic hypermobility, and I don't suspect Marfan's or Lewy Dietz or those things, then I may diagnose them with hypermobility spectrum disorder. It's like the irritable bowel syndrome of our world of hypermobility, right? Irritable bowel syndrome is you go to the gastroenterologist, they do a bunch of tests, maybe if you're lucky, I guess. And then when they can't figure out what's wrong, you have irritable bowel syndrome. And of course, that is something that also is more prevalent in people with EDS. So it's that's kind of like the groundwork for those conditions. When you were talking about working with a physical therapist and getting specific instructions and all of that, it reminded me of an analogy I like to use. If you think about a golf ball and the sweet spot on a golf ball, people who have quote unquote normal bodies, so they have normal connective tissue, their connective tissue has normal strength. And by the way, there's people who I think have super normal strength. So you look at Tom Brady, Michael Jordan, I mean, those guys, like, they don't just have normal connective tissue, they have amazing connective tissue. And they've probably made a lot of really smart choices along the way, to work with what they have. But you take somebody who has bad connective tissue, there's no way you're going to turn them into a Tom Brady. There's no way. We just try to optimize things as best we can. But for us that have hypermobile bodies, our sweet spot is tiny. And especially when we're in a bad place, our sweet spot gets smaller and smaller and smaller. And once chronic pain happens, our sweet spot can be very, very small. The whole goal when I'm working with somebody is to get that sweet spot as big as possible so that they can do the exercises. And maybe if it aggravates their symptoms a little bit, they can recognize that, they can back off a little bit, but they're able to kind of work in a bigger range, if that makes sense.
Absolutely. And thank you for doing all of that. That's brilliant. So I think one of the first things somebody asked me, I guess was my client, I was like, I wonder if I'm hypermobile. She's like, oh, can you like do this with your thumb? Like, can you put it here? Like, yeah, I can do that. And, but one of the things that she mentioned to me that I want to ask you about is when you get to my age, and now I'm loaded with arthritis, right? My childhood hypermobility, which was much more noticeable, is now less noticeable. My knees did used to kind of go back, and with the amount of degradation in my knees, because now they just grind themselves into powder every day, that is not as evident. And I think people who are coming to this idea later in life may not get seen accurately as being hypermobile, because some of that hypermobile has been lost to the fact of hypermobility.
Right.
Can you talk a little bit about that?
Of course. So in 2017, when they were revising the diagnostic criteria for the different types of EDS, and there was a lot of attention paid to the diagnostic criteria for hypermobile EDS because it's a clinical diagnosis. So it's super, super important for that, because since there is no lab test at this time. The Norris lab at MUSC is working on that. We're going to have more information in the future, but for now we don't have a test. So they also defined different types of hypermobility. So there's peripheral hypermobility, which is in the hands and feet. There's localized hypermobility, which is limited to like a couple of joints. And then there's generalized joint hypermobility, which means you have it in multiple places of your body. And then there's historical joint hypermobility, which means that you were hypermobile in the past, but you're not anymore. And that's a very, very important category of hypermobility. That is one of my complaints with the Beighton score. And one of my complaints with the 2017 criteria is that it starts with the Beighton score. Now, granted, they do break it down by age, and over 50 is a category, but they don't break it down by 50, 60, 70. Obviously, you have to decide, right? You have to decide how complicated or simple you're going to make these criteria. And you can gain a point back by something called the 5-point questionnaire. But I like to use the 5-point questionnaire as a standalone tool. And I hope that there are some physicians listening to this, or nurse practitioners. This is the part to listen to, okay? Not that you shouldn't listen to the other parts, but really listen to this part. This 5-point questionnaire was developed in 2003, or was published in 2003 by Drs. Hakim and Graham, and they are the grandfathers of hypermobility. All of us who are hypermobile, who are living with symptomatic hypermobility, these are the people to whom we say, thank you, thank you, thank you, thank you, thank you. They have done amazing research. They have dedicated their lives to helping those of us that are hypermobile and suffering with all these symptoms. So they developed this 5-point questionnaire that really looks at your hypermobility from a historical standpoint. So it looks at, the thumb thing. The first question is, can you touch your thumb to your forearm? Well, but it's worded, can you now or could you ever? So that's the difference. The Beighton score, you have to be able to do it when the doctor's examining you. But with the 5-point questionnaire, it's can you now or could you ever? Now, the challenge with that is, say you're a woman in your 70s and I'm seeing you and I send you this 5-point questionnaire, which I have people often fill out before I see them. And they're like, I don't know, I've never tried to do that. But like you said, they have arthritis and they can't do it. So that's where it can be a little tricky. They also ask about, as when you were a child, did you amuse your friends by contorting your body into strange shapes or doing the splits? And, and yeah, exactly. Like you're nodding. The people who do these things are like, yes, 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 and so the 5-point questionnaire is really, really a brilliant tool. And I love it because it looks at hypermobility from this historical perspective with a historical lens, because the problem is there are phases of hypermobility or stages or whatever you want to call it. And I created a reel about this just to try to make it light and fun. And it's not like this is, there was a paper that was published about these phases, but they looked at it a little bit differently. The way I wrote about these phases, again, this was just a little social media thing that I did, but the first phase is the fun phase. And this is based, by the way, on my own personal experience and my experience working with clients and patients and what followers tell me and, emails I get and things like that. Okay. So the first phase is the fun phase. You're hypermobile, you're a dancer, you're a gymnast, you're able to do all these cool things, but you don't feel anything. You're fine. It's fun. And then the second phase is the mystery phase. You start getting different symptoms. You might have abdominal pain, bloating, diarrhea, joint pain, headaches, fatigue, difficulty with being upright. You go from sitting to standing and you get dizzy, a lot of different things. Like you said, autism, neurodivergency, ADHD, different things showing up. That's the mystery phase. Then the next phase is the painful phase. Oftentimes we get these pain generators coming into our nervous system, and pain begets pain. There are specific physiologic mechanisms by which pain produces more pain in the body. This is like an absolute known thing. So in the pain phase, everything starts to hurt. And then the last phase, the fourth phase, is the optimization phase. And I hope that everybody gets to the optimization phase. In fact, I hope in the future people skip phase 2 and 3 and they go from the fun phase to the optimization phase. And in the optimization phase, you figure out, okay, I'm hypermobile, I've got these migraine headaches, but here's some things that I can do for these things, and you can improve your quality of life, right? It's all about function and quality of life. I don't ask people for the numbers on their pain score for the most part. I care about function. I care about, can you do what you want to do? Can you do what is most meaningful for you in life? And the problem is with the Beighton score, in the fun phase, your Beighton score might be a 9 out of 9, but you feel perfectly fine. And by the time you get into phase 3 and you're having a lot of pain, your Beighton score could be 0 or 1 or 2. So that's why I love the 5-point questionnaire.
That's fantastic. Yeah, absolutely. Just thinking about the kids that I was around, especially in gymnastics, right? If you're waiting for your turn on the mat, half of us were like, what weird thing can you do with your body? What? And
Yep.
There was this one little girl, and I was so jealous of her because she was way more hypermobile than me, and I thought it was cool.
Of course.
Right? She could, the stuff she could do.
Yep.
She looked like she was bending her arm like it was just going to snap off. She could hyperextend her elbows so much and her knees so much, and her shoulder blades. And I just think about all of these kids. And then we were throwing ourselves around in gymnastics,
Right.
right? No one was paying any attention. I remember being in so much pain in my knees in gymnastics that I was crying and getting
Mhm.
yelled at
Oh,
for not being tough enough to do gymnastics. But it was because the stuff that I was doing was putting too much strain on loosey-goosey joints.
right.
I can walk across a room and feel like I've sprained my ankle because my ankle joint has gone off for no apparent reason.
Because you probably have sprained your ankle walking across the room. Yeah.
Right. Yeah.
Yeah.
What? Um, but unfortunately, you're looked at as this like just exceptionally irritating human being.
Right.
And this idea that pain begets pain. And because, chronic pain and things like that are so little understood, and they're
Mhm.
often assigned like an ick to them. I don't know if that makes any sense to people, but like if you tell somebody that you have chronic pain with any of its labels, right, you're just looked at as,
the stigma is huge.
yeah, I can't think of a way I want to describe it because all of it downplays the needs of people who might need psychiatric help or all, right?
Right.
It just feeds the same problem. I can't think of any way to express what I'm talking about without pulling out some of these nasty, awful ways we look at people who do need psychiatric care, right? I'm not trying to say I shouldn't, if I need psychiatric care, I need psychiatric care. I just don't want to be told I need it if I don't, right? And so I
Right.
think this is a thing that happens often, especially for uh, those of us who present in particular ways, whether we're ADHD, autistic, or both. We very often get looked at as people who need psychiatric medication.
Mm-hmm.
I have a very specific event that gratefully my husband was part of because he's my third husband. I did it right this time. And I would tell him what my experience was with my medical care. I tell people, I feel like I can prove it, right? We're constantly asked to prove it.
Mm-hmm. Mm-hmm. Right.
I feel like I can prove it, and I don't get believed, and they send me to psychiatrists.
Right.
And he did not invalidate my experience. He said, wow, that's awful. Do you think it would help if I came with you? I don't know. Let's try, right? So I went to somebody because my knees sound like ratchet wrenches all the time.
Mm-hmm.
If the room is quiet, you can hear me crossing the room. It is spectacular, right? So I went to a primary care style, general practitioner style person. She listened to and felt my knees and said, wow, that's bad. Let me think about it for 2 weeks and I'll talk to you.
Mm.
In my world, I don't know what there is to think about. Send me to a person who knows about joints and knees, right? So, okay. My husband is at that meeting.
Mm.
My husband is then present at the telemed follow-up,
Mm-hmm.
where she says, I have a friend. She's a psychiatrist. She knows all about you and is waiting for your call.
Mm.
I said, okay. I didn't ask you anything psychiatry relevant. I asked you about my knees. What should we do about my knees? Oh, well, I see the psychiatrist. Okay.
Oh.
But I asked you about my knees. Well, give me another couple of weeks.
Mm.
Not only did I not call her again, but I never heard from her again. But I think there are going to be people watching this that are going to be like trying to climb through the screen to get at us and say, that's my experience.
Right.
I can prove my problem. You can hear it. You can see it. You can feel it. Why won't you give me care?
Mm-hmm.
Do you think there's something about the neurodivergent hypermobile experience that lends to this go see a psychiatrist thing that happens. If you look in social media, if you go into autism women's groups on social media, if you go any place they're talking about neurodivergence and medical care, you're going to see my experience over and over and over again, where we can prove we have a real physical condition and they send us to psychiatry. And they won't see us for the physical condition until we've been obedient and seen the psychiatrist.
Right, right. And I've had that exact same experience, by the way. I was dealing with a knee problem following a bike accident, and my orthopedic surgeon was trying to give me antidepressants. And by the way, this is when it's still a very acute problem. And I had already been having, to me, part of the problem is the psychiatric portion can be part of the answer, but the problem is people look at it, other doctors will look at it as the whole answer. And it's like, no, that's only part of it, because there are I know some people in the space of chronic pain and looking at like the psychologic aspects, and they'll talk about it like it's just a psychologic problem. And it's like, no, you forget that we have a biopsychosocial model of pain. Pain is a biopsychosocial problem. Biologic starts with biologic. It's a biologic, also can be psychosocial problem. So if you have chronic pain, you need to look at all of those aspects. You need to go look at what's going on in the tissues. Then you can look at what's going on in the nervous system. And yes, you can also look at what's going on in the central nervous system, i.e. the spinal cord and the brain. And I think, to answer your question more specifically, I think the reason why so many of us, including me, have been gaslit, have been labeled, have been poorly cared for, is because a lot of us, myself included, have anxiety. When we come into a doctor's office with our anxiety, which, by the way, anxiety is highly comorbid with ADHD. When we come into the doctor's office with our anxiety, we're energy beings and they sense our anxiety. And oftentimes, I think what's happening, it's not got a study to back this up. This is more my personal opinion and professional opinion from working with patients and, myself hearing what these surgeons would say. Because remember, I was in the operating room for over 20 years, and I would hear what these surgeons would say about, oh, my next patient, blah, blah, blah. They'd be telling me about what the next patient, what I should expect. And so I think what happens is they latch onto that anxiety. They sense the anxiety. It makes them anxious. And therefore, they think that that is the most important aspect of the problem. And I think that's why they send us there.
That makes tons of sense. I mean, especially because right now we've got study after study coming out about the negative physical impacts of persistent stress and anxiety. And cool, awesome, great. But we have to yes and, right?
Exactly.
And I think understand for each individual human being, what is the chicken and egg scenario, right? So you talked about fun, pain, transcendence, whatever, right? Like I birthed into pain, right? I don't have a memory where my body didn't hurt.
Mm-hmm. And that is some experience. Yeah. They never were healthy. That before the pandemic, I had very long initial visits, 4 to 6 hours, and I would have people start their timeline from before they were born. And yes, you are not alone. There are some people who, yes, they can never remember being without pain. That's not everybody, of course, but there are definitely people who they had health problems from day one.
So did SAD come along with being in pain? Yes. Right? Did anxiety come along with being in pain? Right? Never knowing what was going to be the thing that was going to shoot pain like lightning bolts through my body or keep me up all night long, or, the migraine headaches, right? And not having people listen to you and believe you. Might I have become anxious? Right?
Right. Right.
Might lessening my stress and anxiety help me? Hmm. But if we chicken and egg it, I have all of my memories come with sad as a companion, but I'm understanding that as a neurodivergent mental emotional processing thing, right? So if I let sad talk all the time, depression will happen, right? Sad can be there while I'm enjoying myself, right? So understanding that sort of population of the brain, right? Our neurodivergent selves can often be very populated.
Mm-hmm.
You can have a lot of, a lot of things going on all at once. So yes, I think of myself as always being companioned by sad, but not always being depressed.
Mm-hmm.
And I don't need sad medicated,
Mm-hmm.
right? I need sad understood,
Mm-hmm.
properly attentioned, if that's a word, right? I need to give proper space to sad if that's a constant companion, but that doesn't mean I need to medicate sad.
Mm-hmm.
It means I need to know how to walk my life. If that's with me all the time, it means I need to know how to successfully walk my life with this companion. In the same way that somebody who is likely to be like super hyper and intense. Oh, bummer. There you are.
Oh no,
Hello.
I'm so sorry. You were frozen and I was trying to do something to unfreeze you and I disconnected us. And I'm so sorry. But I do have a patient coming up soon.
You do, yes. We
So that
went
gives
way
me a
over
great
time.
opportunity to tell you that. So
Yes. I've been so excited to talk to you. We went way over time, and I appreciate that. And I'll do something to neat and tidy that up.
And if you and if you want to, if there's things that you want to ask that we could do a follow up and meet again or something, I would be open to whatever,
Okay,
whatever you need. Because this, I mean, I think this is it's a great thing that you're doing and really, really important.
Thank you. I appreciate that. And just so you know, you'll get free access to all of the
Oh,
virtual program. So
thank you.
it's 30 plus hours of all kinds of different people. So you'll have fun picking and choosing. But thank you. Thank you so much for doing this. Your input has been invaluable. Your explanation's clear. This has just been a really, really wonderful experience. So thank you. Any links you want to send me,
Okay.
your podcast, other podcasts you've been on, any links you want to send me, I'll put them connected to this video. And I'll do all I can to make sure you have audience.
Well, good. Well, I appreciate that. I mean, I don't know if you can insert this someplace or not, but when you were talking about your experience in gymnastics, this is one of the things that makes me absolutely crazy. When I don't know if my anxiety is serving me well in this scenario or not serving me well, but when I see a classroom of dancers or I'm at the gym and I see a room full of young people doing gymnastics, and I see, it's funny because people talk about these as being invisible disorders, but at the same time, they're the most visible disorders in the entire world, right? Or they can be. You can be hypermobile and not have a problem, right? You can be hypermobile and be pre-symptomatic. We don't necessarily know. But when I see these people and then I see the crazy things that they're doing, and I see that the coaches and the teachers have no clue what this might mean, And, we have to be careful because we're asking coaches and teachers to know a whole lot of things, right? I mean, we're in this crazy era between COVID and, sexual misconduct and all of this stuff, right? We're asking them to know a lot of things. We're asking them to, and also things like REDS, relative energy deficiency, kids that are not nourishing their bodies appropriately. So we have all of these problems going on that we're asking coaches and teachers to be aware of. I just want them to be aware of hypermobility enough that they point the kids and the parents in the direction of resources. Go listen to the podcast. Go check out, the EDS toolkit, the EDS Society website. EDS awareness has great webinars. There's all of these great resources and tools that are available to people, but they have to know about them. And the coaches and the teachers are often, people who are seeing a lot of this. And so if we make the coaches and the teachers aware, to me, it's like a win-win. They can retain their students longer, because if they have students like you that are having terrible knee pain, how long are they going to last? They're going to be out of that program before you know it. But if instead we can give them tools and say, look, you can maybe continue your activity for longer if you take better care of your body, if you slow things down, if you work on joint stabilization, if you work on deep motor control, if you work on better neuromuscular repatterning, if you work on these things, then you can have a better quality of life and you can use your body longer, better. And we know that there are other things that are probably impacting all of these conditions, like environmental things, like environmental toxicants and things. So this is becoming more and more important because, mast cells are part of the immune system, and the immune system interfaces with the environment. So as our environment has become, more and more problematic, we're asked to interact with a lot of things. We really need to have as much awareness of this as possible so that as a society, we can be functioning as well as we possibly can. So to me, it's like a public health emergency.
Yeah, I'm with you. And you have to go and I have to go. But one of the things that I'm super interested in is the connection between hypermobility and concussion.
Oh,
If we're not able to stabilize our connective tissue in our necks and stuff like that, we're banging our brains around a lot more than somebody who has good connective tissue and their muscles aren't overworking to stabilize and stuff like that. So there's just so much. Yeah. If we're talking about the little kids in the sports or the teens in the sports, knowing hypermobility could be, not just pain saving and, lead to better lives in the future, but in some cases, literally life saving, right?
Mm-hmm.
We're not going to accidentally re-injure and re-injure and re-injure until somebody's at risk.
Correct.
So again, thank you. Thank you. I know we will talk again.
Wonderful. Yeah, it was fabulous to chat with you. Thank you so much for inviting me. I think this is such a great conference and I'm honored to be a part of it.